She's been observing on Mondays primarily, and she's working on her bachelor's degree. And one of the steps of that is to present some information, or present a class. The fabulous part about the class that she brought to present to us is about silver diamine fluoride, and that is something that we are, as a clinic, working on implementing. So this is going to be a real good information source for us. So with that, turn it over to you, Dr.
So you all know, you've seen me around before. So as she said, I'm getting my bachelor's degree. I work in a clinic that's all, OHP is all the patients that we see. And we use the silver diamine fluoride a lot and in different ways. And I've been to some of the other of our clinics that I work at, and they use it there, and I've just seen some really different ways that they're utilizing SDF. So I'm really excited to tell you about how you guys can use that in your clinic. And I just put up, this is Wade Community College.
There we go.
Oh, there we are.
Okay, now I'm happier.
So these are just some pictures of what it looks like. The top two right up there are just, one is where SDF hasn't been placed, and the other one is where it has been placed. And these are all, and you can see how that turns that dark. So this is what we're going to be talking about today. And this is the, when you get through with this, hopefully you'll be able to understand the mechanism of action between what the silver diamine fluoride, there's several ingredients, or 2 or 3 ingredients in there, and I want you to know what each one of those ingredients do. We're going to discuss when you should use it, when you shouldn't use it, some of the safety things that go along with that, what patients might be concerned about, what the challenges are to convince a patient that this would be good for them. And of course, at the end, you should be able to do the steps required to place the silver diamine fluoride. And if I'm not going to say that, so if I say SDF, you'll know what I'm talking about, so I don't have to say that whole great big word. Well, let's first start out, what is silver diamine fluoride made of? So let's just look at the, well, we missed one here. How do I make it go back? There we go. Oh, I'm missing a slide. All right. All right, so we're going to be, I'll give you, the first part is the background, what SDF is, why do we need to use that in your practice and as a hygienist. We'll talk about safety issues, we'll talk about contraindications, precautions that you need to take. Who can place SDF? That'll be an interesting conversation there. Indications. What we've found in the clinic as we are using this and how we've changed protocol. This is relatively new for us, and of course you'll learn those steps at the end. So let's talk about the background. It's been used worldwide. All over Europe, it's been in Australia, it's been in New Zealand. Europe uses it, they use it in third world countries, but for us here in the United States, it was cleared by the FDA in 2014, so not so long ago. It's relatively new for us. And then in a year ago this month, it was, the FDA recognized it as a breakthrough therapy designation for caries. So they designated it as a breakthrough therapy. That doesn't happen very often, but SDF got that because they were seeing such good results from it. Research is evolving, particularly here in the United States. There's tons of it from Europe, but here, not so much. And so protocol on how to apply it and use it is changing. In fact, the protocol that I have clips of how to do it, and that's changed since I got the clip on here 3 months ago. So it's changing and evolving all the time. And so, well, when I put these on here, we'll discuss some of those things that are a little different, even though that's what I have up here. Care is managed by a risk assessment. That's Canberra. And that's a program that has incorporated SDF into their into it. And so it's a vital part of it because it includes doing a caries risk assessment. Do you guys do a caries risk assessment in your clinic? About how many questions is that? Do you remember?
We just modified our treatment plan. The students are going to get a copy of that.
I'll do that next week.
Okay.
Next week.
Okay.
There's about 12 questions on our old one, on just the carries.
Okay, so you're getting a new one,
We modified it to more closely match.
Canberra? Okay, great. Great. Yeah, they're kind of the leaders in all of this. So, and a caries risk assessment, as you know, identifies the risk factors for a patient and why are they getting cavities so that we can go about eliminating those so that becomes from a high-risk patient to a low-risk patient. So what is SDF? There's the formula for it. Well, let's go to our chemistry class a little bit here. What does AG stand for? Silver, that's right, silver. So what does the silver do in the silver diamine fluoride? Well, it's the antimicrobial. That's what kills all the germs that's causing that cavity. And it's also has substantivity to it. Do y'all know what substantivity is? That means it hangs around for a long time and it works even though some part of it has gone away. What happens is when that silver hits the bacteria, it kills the bacteria, but even the dead bacteria can kill live bacteria. So even though these dead, that sounds kind of gross, doesn't it? All these dead things are floating around in there, it kills the live ones there. So it lasts for a long time before it's not bioavailable anymore. All right, then we have the fluoride. That's the F part that's in there. And we know you've all been using fluoride varnish and how well that remineralizes the decalcification that we see in the demineralization. Silver diamine fluoride has 44,800 parts per million. Does anybody happen to know what fluoride varnish has? So, half that much, about half that much. That's what. So this is really, so we've got two good things here. We have the silver that's killing all the bacteria, and we have the fluoride that's going to remineralize and strengthen that tooth structure that's left there. And then, what does the N and the H stand for? This is the part that makes the silver diamine fluoride taste really gross, and you wouldn't think you'd ever want to put this in your mouth. It's probably you probably have it at home somewhere. Maybe you use it in your washing machine or you have it under the sink as a cleaner.
Ammonia.
Yes, it's ammonia. And that's the stabilizer within this formula right here, because it's so highly concentrated with fluoride and silver that they need it to stay stable. So that's what the ammonia does, but that really makes it taste really, really bad. So that first one up there, I think, is the biggest reason for using SDF, so that we can avoid using more invasive treatments. So what's one of the reasons people really hate to go to the dentist? What's their biggest fear? Pain, and they don't like getting a shot. So there's no injections when you use SDF. What's the other thing they don't like that the dentist uses? The drill. No drilling. Or some like to do a little teeny bit, but not where they would have to have injections. And for little kids, this next one is ones that I think is really highly important for them, is because a lot of those won't have to go under general anesthesia to have their teeth taken care of. They can put on the SDF, get it stable, and maybe down the road they might still. In some parts of the country, it's really hard for kids to get into the hospital to have general anesthesia. Some of them are taking up to a year, sometimes two, depending on what part of the country you're in. Here, it's around a month to 3 months to get in to have general anesthesia. if they need it, but hopefully they might not. It's also great for patient behavior management, for those, when that can be very difficult, when we have to modify something. Sometimes, even though we put the SDF on there, there may be a filling or restoration type that needs to be done. We use, in our clinic, we use GI, glass ionomer, and we have a couple of kinds that we use. One that we like here, and one that's called Equia Forte, which is really super hard, and we can even use it on posterior teeth. It's as strong as amalgam, just about, but it has a higher concentration of fluoride in it, so it's really good to put in these lesions that have gone away, pretty much. Not gone away, but they're not active anymore. And to me, that's a big wow. I mean, can you imagine that? I mean, how many patients, if you told them about silver diamine fluoride, who's just won't hardly even come to your clinic because they're so afraid, and you can do something for them that will help stabilize them until you've won their trust, then you might be able to do something more definitive. But there's lots of patients that we're going to be able to help with SDF because they're just so afraid to come in. And I've had those too. And the little children who are really young, like before they're even a year old, you can apply this on there too, so that they can wait a year or two before they're maybe more cooperative. Maybe they won't even have to go to general anesthesia. Maybe it's enough to stop it just so that they can wait until they can get some other kind of treatment. To me, that's just a big, big deal. Well, now that we know some of those ingredients in there, how safe is it? It's remarkably safe. When we're using the silver diamine fluoride, we're only using about a drop. And so the max dose is 1 drop per 22 pounds. Does anybody here have kids that weigh 22 pounds? Anybody?
I think Lola does.
Okay. How old?
1.5.
Okay, a year and a half. So you can use a drop and you're able to treat 5 sites. I found out that you could probably really get more like 6 or 7 out of it, but they're being conservative, so they're saying 5. And most of that's usually on those anterior teeth. So 1 drop is equivalent to drinking a liter of fluoridated water. So how safe is that? So topical application of SDF is very safe, very safe. In fact, there is less fluoride in a drop of SDF than there is in one of your little things of fluoride that you paint on their teeth, the fluoride varnish. So what would be some contraindications? What's the first one you always think of in medicine? What's that? An allergy to whatever it is that you're giving them. Although people say they're allergic to silver, most of the time they're allergic to nickel. But if someone told me they were allergic to silver, I'm not going to say, oh, well, I don't think it is. I think it's nickel, you know. You're just going to say, okay, we probably won't be using this for you. If the tooth is symptomatic, what kind of symptoms would you might imagine that someone would come in that you wouldn't want to use SDF on?
They have like an abscess too?
An abscess, yeah. Yeah. What if it has that achy kind of feeling? When the doctor looks at it, if it looks like the pulp is exposed, they're having hot and cold sensitivity, all of those kinds of things. And the doctor's the one that kind of determines whether that SDF can be placed or not. And you only want to get that SDF where the lesion is at. You don't want to get it out into the tissue. You don't want to get it on their lips, clothes, that sort of thing. Because it stings. That ammonia makes it really sting, and the silver kind of adds to that too. So keeping that tooth isolated is important. And if they have like a little, those ulcerations that you can get on the inside there, an apis ulcer or whatever, if it's on the corner of the lip or, you know, on the vermilion border, it's probably not that big of a deal if you're careful how you put it in there. But if they have one on the inside where you pull out their lip and they have lots of ulcerations underneath there, you're probably not going to want to be using SDF that day. It also stains it's kind of like a little tattoo that gets on the skin. It's a little dark gray, could be black. That goes away in about 3 to 10 days or so. But, you just don't want to do that to your patient if you don't have to. The other thing that it does, it stains the clothes and it stains the countertops, so you have to be really careful not to get that on your fingertips and then touch something else, because it's the same, it's like water, so you can't tell where it's going, so you have to be really careful. And we have a way to be able to make sure that that doesn't happen. And then, of course, you have to inform the patient that it has fluoride in it, because in Eugene, we know lots of people do not like fluoride, so it's important to inform them that there is fluoride there, and that it will turn those lesions black. Now, a lot of the parents, when they were asked if they wanted to put silver diamine fluoride on their kids' teeth, a lot of them said, oh, no way, you're not going to put them on the front teeth. There were about, 25% of them said, more said, well, if you put it on the back teeth, it's okay. But if you said, this is an alternative to going to general anesthesia, there was quite a few more that said, yes, put SDF on my child's teeth. So as the need grows for the patient, then parents are more accepting of where that can be placed. So I put this little graph up here so that you can see the comparison of how much fluoride is in each of those common things that we use every day. So you see that there's the fluoride varnish, which is about half. The in-office bleaching trays that you do, that's about half of what the varnish is. And then you have over-the-counter fluoride rinse. The Clean Pro 5000, that's the RX toothpaste, is also. Prevident 5000 is similar to that. And then just regular toothpaste is about 1,000 to 1,500, it kind of ranges. Anytime it gets over this 1,500 mark, though, it's considered a prescription and you need an RX for that. So, and there's another, this is a really good picture of what it looks like before. And then if you notice, even up here, see how they've gotten the silver diamine fluoride clear up here? Now when it gets on the tooth, it only stains where there is a cavitated lesion, where there's actually decay. So you can see where they've gotten it here, but you can see here, also where it was here, and then here. So it's gotten a little bit, you can see where they got it on this other tooth over here a little bit as well. So and I'm not sure that's the tooth or if that's the tissue that it got on there, but you try to keep it within where the lesion is that you're wanting to apply that. So who can apply the fluoride varnish? I mean the SDF. Anybody that can apply the fluoride varnish can do SDF. So within our clinic, who does that include? Speak up.
Us.
Yes. Who else?
Dentist.
The dentist?
Assistant.
The assistant?
Assistants can.
Okay, so all that. What about in a medical clinic? Who could do it there?
Could be the trained back office assistant.
Yes, absolutely. Anybody that's been trained to do that, they can apply fluoride varnish, so they could put on SDF as well. That could be their nurse, it could be their, assistant, anybody that's been trained that could do that. In a nursing home, same thing. It's great to be used for the elderly who have a hard time getting to the clinic. So indications are people who have high caries risk or the extremely high. So who do you know, and the patients that you've seen tend to always have decay? What's a problem that they have, which I have right now, is a dry mouth, yes, and that causes them to be very high risk for getting caries. So this would be a great tool to use for them. We also, another extremely high risk is severe early childhood caries. And those are those children that are less than a year old who get caries rampant, throughout their mouth. And have you seen any of that in the clinic at all? Children that have lots of caries? Arresting a lesion before caries removal. And I saw this in the office that I worked in the other day. There was a a patient that came in that had a decay was close to the pulp. It wasn't all the way to the pulp, so they put SDF on it instead of doing anything, saying, if we don't have to do a root canal on this tooth, we don't want to have to remove all of that tooth structure. So they put SDF in it. They waited a week or two. They brought her back, put SDF on it again. And then another few weeks down the road, they brought her back to do another caries risk assessment to find out if that if it stopped, had it gotten hard. And when they went back in there to look, it had turned that whole area really hard. So when she went back in there, she didn't have to do the root canal. She removed a little bit of caries in that area, but not enough where she had to do, and then just put GI filling on the top of that. And so in 3 months, they're going to bring her back again to check to see how things are going along, make sure there's not any pain, any symptoms that are gone with that. But isn't that great that she didn't end up having to have a root canal on that tooth? And to me, that's what SDF is for, so that we don't have to do all of the invasive things. Have you had patients that have come in who have just tons of cavities? Have you seen that before? And that's going to take a lot of appointments to get them done. So if you can put SDF on to stop the progress of the disease and then bring them back as often as you can to do the fillings, and then all that bacteria is not getting all over into other areas as well. You're stopping it and controlling it. You can use it for patients when there's a long time between getting an appointment or between one appointment and the next. And for some, especially in the population that I work with, sometimes it's hard for them to get in if they're homeless, if they don't have transportation. Sometimes it's just because there's, in some other offices, not ours, I know that it's 3 months once you come in as a new patient before you have your first new patient appointment. So it really takes a long time. So when they come in, you need to try to stop that progress of that disease and use that fluoride. Also, when they're too medically compromised, maybe you can't give them anesthesia because of a certain condition. Maybe they can't open, maybe they can't. There's just lots of things of why you might want to use SDF on a medically compromised patient. Behaviorally challenged. Do you have those patients who are just scared to death to come in? Have you seen those? Yes. How about the child who is just doesn't have a very long attention span? Yes, yes. And you might have a minute is all the attention you're going to get. So what can you do? What's the best tool that you can do for him while they're there? Notice I said a he, I don't really mean he. The next one is, have you ever seen decay within a furcation? Underneath of the tooth? Impossible to get in there to treat that with our standard methods of getting in there. But you can take that little tip and get right in there and put SDF on that root surface and stop the decay, so that they might be able to keep the tooth for the rest of their life, possibly, or at least to hang on to it for a while longer. It also can be used around, you know how crowns can get decay up kind of underneath of the edge of that? You can put SDF, I've done that many times around the edge of that crown. You can put it on partially erupted third molars in the back there where you couldn't get a drill back there, but you can get a little tool back there to put SDF on that surface that's there. What about those people that have limited access to dental care? Maybe they live far away, way out of town, and they don't have a car, so it's hard for them to get in. If they come into the clinic, you want to do as much for them as you can, but also stopping the decay. So you can put SDF on there. When you explain, it's going to turn it dark, but it's not going to then spread and cause other cavities in other areas. Maybe they have financial resources. Maybe they don't have the money to do all that needs to be done. SDF is also a desensitized, I was gonna change it, I forgot, it doesn't mean no drill, that means no anesthetic is what I meant there. So, with that, we wouldn't have to drill. And what about a patient that requests more conservative care? Maybe they don't feel that they want to have a drill and fill and shocks or any of those. So anybody that wants to do a more conservative treatment, SDF is another great choice for them. Here's some things that we found in the clinic. That you need to do at least 2 applications to get the best results. With one result, that you get about 70% arrest the decay. If you get 2 applications, and usually you want to wait probably a week or 2 before the next application is. Some wait 3 months. You get 90% of the cavities are arrested. That's pretty, isn't that like, oh my gosh, that's a big, that just blew me away when I heard that. So we put it on twice, sometimes we'll put it on a 3rd time as well. So we do 1 when we first see, oh yes, you would be a good candidate, we'll apply it, bring it back in a week or 2, apply it again, and then 3 months down the road we have them back and we do a CRA, the carries risk assessment, to find out, have we stopped the decay? Has it turned hard? Does it have that leathery feeling? Or is it still really soft and mushy? And yeah, we need to do something more definitive than that. So let's look at, this is let's see if it really works. This is the armamentarium for setting it up, and she shows you a lot of different things that you can use. So, and you're going to probably narrow this down to maybe a few of what she's got laid out here. Is there sound that we can turn up? That kind of sounds Halloween-y, doesn't it?
So are you saying with SDF that it can actually technically replace a filling? Because if it arrests the cavities, you
Absolutely.
might not even need that.
Yeah, you might not even have to put a filling on it.
Another one.
Right.
Or another one.
Holy moly.
So once everything's dry and
How's
isolated,
that?
you're ready to
Very
go.
good.
So you're gonna put 1 drop of the SDF into a plastic dapping dish.
Did
This
you
is
hear
very
that? A
important.
plastic
You don't wanna
dapping dish,
use
not a glass.
dapping dish because the SDF will actually react with the glass, so use a plastic dapping dish. Make sure you're careful when you're holding or handling the bottle. I don't know if you can see, there's a little drop of black on here. It migrates. So make sure you're wearing gloves. You never want to set it down on a bare countertop. You'll notice over time you'll get a little ring around the bottom of the bottle. You'll even see it inside the box. So just make sure you're careful because you don't want to stain your countertops. I apply it with a little fuzzy micro brush, and just a regular micro brush is all I use. Probably has to do with the fact that I do a lot of interproximal lesions with the super floss, and I find that other brushes were snagging the floss, so just a fuzzy micro brush is great. And then we're gonna leave it on there for 1 minute, so I like to have a little handy kitchen timer set for 1 minute, because that can feel like a long time, so it's good to have a point of reference. And then once it's done, I like to cover the area with varnish. So for a couple of reasons: 1, to cover it and prevent saliva from washing in the area, and that will give more time for the silver diamine fluoride to absorb deeper into the enamel and the dentin. And another benefit is the taste, because the varnish tastes better. I like this 2.5% varnish from Elevate Oral Care. It's nice because it comes in a bottle, so you can put 1 drop of that next to your 1 drop of SDF. So it reduces waste and cost associated with, say, if I were to open an entire unit dose of varnish, I'd be throwing a lot of that away. So this is more convenient and cost effective. And then of course you need your little brush for the varnish. And then if you want
The
to
part
be
that
really
you
nice,
missed is that,
because the SDF
notice that she's
can have
using
a
the
little bit
bib
of
there as
metallic
underneath,
taste,
that's
even
because it has that
sometimes
plastic
when you're
barrier, so that if
varnish,
anything spills
you
on
can give them a
the
little-
bib, it's not gonna soak
All over.
through. So, and you need to make sure that that is
you
also
keep
for the
everything
patient
in
as
a
well.
little Tray, and this is just plastic tray we probably got from Walmart or the dollar store, but you keep all your supplies in here. Makes it nice and convenient. So you can make that your own depending on how many operatories you have. It's nice because you can carry this from room to room. And that's pretty much it.
Okay, so we're gonna go through these fairly quickly because most of these are stuff you already know. Of course, you're gonna wear your PPE when you're doing this. You're gonna give the patient protective glasses and you're gonna use that plastic lined bib. You're gonna place that 1 drop in the SDF little plastic dish. In some of the videos that you see here, for the kids, they put a petroleum jelly on the outside just in case they move, it doesn't get on their, the SDF doesn't get on their tissue. That's one thing that has changed. They're saying, you know, that's not so much. They found that they haven't had any really big problems with that. So, you know, if you want to put that on there, you can. If you happen to have a kid that's really wiggly or something and you're afraid that might happen, a little Vaseline on there will help that from getting on there. Just make sure you don't get any of it onto the lesion, so you don't want to be like overly generous with it. You want to be a little conservative with how much you're putting on there. You want to have your air water syringe to dry with, or a 2x2 also works well. You want to isolate the area with cotton, and she had a lot of different things out there that you can use. She had the triangles and the cotton rolls. You can use 2x2s, whatever you want to just keep that area isolated. And some kids that are really, really good, I don't even have to use anything, just retract with my mirror. You really need to desiccate the lesion. Desiccate means you mean super dry. That's like bone dry. You don't want any water in that area when you're getting ready to put on that SDF, so it needs to be super dry. You want to saturate the microbush with the SDF, and then you kind of want to push it onto the side so you get that extra drip that's usually on the end of that, so that when you're bringing it from where it is to the patient's mouth, you're not dripping that on the floor or along the way as you're coming to their mouth. So kind of just tap it on the side of the DAP addition, it'll remove a little bit of that excess. You're going to take that little microbush and just going to kind of scrub it all around in there. You want to kind of dab it in there first, kind of let it flow, and then you're going to scrub it in all the area that you want to apply that. And then you let it sit for a minute. That's the ideal time, if you can get them to sit for a minute. If you can't, as long as you can get them to sit there, but then you want to put that fluoride varnish over the top of it, so hopefully that would seal it in there. But the longer you can get them to sit there, the more of that SDF will soak into that tooth structure. So the longer you can set it there, the best. But if I could take all of those instructions and break them down into 3 steps, here's what it would be. Dry, apply, and dry. So if you could remember those 3 things, all of the other stuff you already know, because you're going to already have something there to put it on with. You're going to have your PPE on, and you know about putting on the safety equipment for your patient. So these are just the steps that you're going to have to remember. Dry, apply, dry.
The last dry is just to
Just to let it kind of soak.
varnish on top of it, is that what you mean?
Yeah, before you put, and it just allows that SDF to soak into the tooth. That's what it does, it soaks into the tooth. So the longer it sits there, the deeper it can go, the more it will soak into that tooth. So here, the first one here is an application of SDF on a child.
All right, ready, honey? We're gonna put
She's
some
really cute.
Vaseline.
She's very cooperative. This is unusual, but. And there's the Vaseline she's putting
You
on.
were the best.
See how it works? To me, that's just a little much,
Any
but.
staining on her face, because if the silver gets on there, it will leave like a temporary tattoo. But it'll come off within a couple of days, week, just depending on her, how fast her skin cells turn over. Can I see your cute little teeth? Yeah. You're the best. So let's see. There they are. Okay, I'm gonna dry them off. Can you open big? It's almost like they're stained with whatever candy or something that she had. Pretty good. Can I have the air, please? I'm gonna dry it too. Sure.
This is a very cooperative
Ready? I
patient.
have air. Tickle, tickle. More air. Good girl. You're doing so good. Pass me the. Oh my goodness. It's still open really big. Good job. Oh, you're the best. Good girl. So yeah, see how I have her lip up? When you're brushing her teeth at night, just look up there and look for any pimples or inflammation that would indicate an abscess, because these two are pretty severe, but we might be able to get them to reminimize it. It's worth a try. And then in 2 to 4 weeks, come back and we'll do this again, and I can put a material over these holes called glass ionomer. It'll help mask some of the dark color, and then it'll also help her tooth to heal. And hopefully we can save these front teeth. But you'll be adorable regardless. You can start the timer just for 1 minute. I'm gonna do 1 minute. See how it's starting to turn color already? So once it gets exposed to light, it'll really color. Oh, you're so sweet. The best little baby. Is she always this good?
She likes to brush her teeth, just like candy too much.
She does like candy. Who doesn't, right? I like candy too. Good girl. So we're just gonna wait 1 minute, and then I'm gonna put some yummy, yummy vitamins on your teeth, and then you're gonna be all done. Good girl. Pass me the varnish. About 20 more seconds. Doing good. So this is her fluoride treatment. I'm just gonna paint it over her teeth when we're done here. Let me do your other teeth first. Oh, it's been a minute. You have been amazing. Can I get some more of the varnish, please? Thank you. You are the best. Can you open really big? Ah. I'm gonna cover those up. So you can actually skip brushing her teeth tonight because the varnish will still be.
And that's pretty much it. So.
Hi,
how
I'm
do I
Jeremy.
start this?
All right, ready, honey? We're gonna put some Vaseline on you. It's like lip gloss. All right, ready, honey? We're gonna put some Vaseline on you.
Okay, now this is one for an adult. This one is pretty quick.
Hello, we're going to show you how to apply silver diamine fluoride.
I thought on the, she put SDF on there a lot, she dipped it. It really doesn't take that much. I mean, if you only get in there once and can sweep it across there, and that's all the opportunity you have, that really does a good job with just the one little sweep across. So if you can get two, yay, you know, but.
Pre-bend our micro brush.
Now see how minimal his setup is? He doesn't have a lot.
Okay, if I bring you back. You're gonna hold it for us? Thank you so much. So we're gonna take some cotton and isolate the area. We're gonna be applying onto number 30 at Boozle, the first permanent molar. So we have our air water syringe. Make sure that you're just getting air. Apply air until the tooth is nice and dry. I'm gonna get our silver diamine fluoride. If you don't mind looking at the microbrush, we're gonna drop, remove excess on the side of the dappen dish. Bring this over to the patient. Open real big. Thank you so much. Apply to the affected area. You can see there's a little pit in the occlusal. That's it. And now we're going to let this sit for a whole minute. And then we'll rinse. Okay, suppose our full minute. We're going to come back here. We're going to use the cotton that we used to isolate to soak up any excess silver fluoride in the area. And then we will rinse. Let's use the saliva ejector, some water. That's it. So lastly, I'd just like you to see that we have a plastic lined tray cover, so the silver stain, which you can see the brush is already starting to stain, that it doesn't get onto our counter surfaces. We like to take the materials and wrap them up in our gloves, like so, to decrease the chance of stain. And then we throw everything away.
You see how he did that?
He is
He
fine.
gathered up what he had and then took his glove and wrapped it over the top of it so that it just all stays within that glove and then you throw it away.
The other thing at Lane is the container of the stannous fluoride or silver diamine fluoride. We don't leave those containers on the tray surface that's going to be the treatment area. We'll put it in something or somebody can drop it on your, as one of the students and I did, dropped it on the brush. But we don't put that little container in the treatment area. So you put it on a cart or on the side, or fill your dappen dish. Okay, as we keep it. And then we always disinfect it after use, but we don't put it on the tray.
So here are the codes. That first one is probably the ideal code to use, but you can use those other ones. It's a topical, they consider it a topical application of fluoride too. You can use it as a desensitizer, or there's just that vague one that's down there on the bottom if you, but usually when it says by report, that means you have to write something to the insurance that says, I'm using this because, and you do a little narrative about why you're doing that. If that's the code that you're going to use.
So, Lynn is being reimbursed for Carrie's arrest for 2 appointments or 3?
I'm not sure, well, with OHP patients, they're not getting reimbursed at all because it's
Part of the.
it's part of, yeah, yes, exactly. And you know, with OHP, you just get X amount of dollars per month. So whatever you do during that treatment time, that's all the money you get for that month. So that's how that works. It's capitated. So let's look at our little summary here. So could you, if I said, okay, what does the silver diamine fluoride do? What's the silver do in the SDF? What does it act as? Killer. Yes, it's the antimicrobial. Okay, and then what's the fluoride? Remineralization. And the ammonia? Stabilizer. Very good. And you can fill in the answers on your little test that's there as we go along here. Okay, what kind of a patient would you want to use this on?
High risk.
Extreme carries risk.
Extreme carries risk. Name a patient that you might that you might do this with.
Xerostomia.
Somebody with xerostomia.
Severe early childhood.
Yeah, that's severe early childhood carries.
Behavioral challenges.
Yes, behavioral challenges. Very good.
Fertility.
All right, furcations, yes. What about contraindications? When would you not want to use it? Okay, if they're allergic to silver. Say it again.
The tooth is symptomatic.
The symptomatic tooth, If they have those lesions, big lesions on the inside of their lips, you wouldn't want to use it then, because that would really sting. Okay, we've identified some challenges that are associated with the SDF. Some of it could be the taste. There's fluoride in it. Big one, it stains it black. So you really need to make sure that you're talking about those things with your patients before and after you have applied it.
It's always temporary, right? The stain?
On the tissue. On the tooth, it is not.
So
That's a
it's
permanent stain on the teeth, where the carious lesion is. But as I said, that can be, you can cover it up and mask it a bit with GI, with Class A on.
So is that billed as a filling when you're masking it?
Yes, you can. If it's, you can either do it as a temporary filling, or you can do it as a permanent filling as well, when you're using GI. And there's different codes for each of those.
So a hygienist could use a temporary filling.
Yes,
Now, the other question I have, does the dentist have to do an exam on the patient before you provide the care?
yes.
Can an expanded practice clinician do this in their own practice without a dentist?
That one I'm not sure of. I can find out though for you. Okay,
So you have to convince the dentist to do this before you can do it,
yes.
because.
He has to diagnose that
that's what
there's,
happens a lot with dentists, you have to convince them, sorry, doctor. As a clinician, it seems like that hygienists are in the preventive realm heavily, and that sometimes it's our job to inform and talk it over with the dentist so that we can use some of these new therapies.
true.
That's
True, and Sharon, and as this goes on and it's used more and more and they see how well it works and, that may come our way that we'll be able to do it just like we do fluoride, that we can apply it whether the dentist says
okay.
it's okay or not. We can determine that for ourselves. So that may be down the road. So what's the 3 quick steps? Oh, no, I'll answer your question. To applying it, did I say? Dry, apply, dry. That's right. And he rinsed it off at the end, and I think the rinsing part is going to be whether the patient says, "Oh, I need a rinse. This tastes horrible," and then you've got to rinse it out. But if it doesn't bother them, don't dilute whatever's in there if you don't have to. So that's the end of my presentation. Don't forget to do the little quizzy thing and put it in the table in the back. And there's a little evaluation that I want you to turn in too. If you don't have time to do it right now, I will be in the clinic this afternoon. You can give them both to me then. Thanks.
Thank you.
Hope you learned something.